I'm a medical oncologist just around the corner here at the Netherlands Cancer Institute. In addition to that, I'm an epidemiologist, and I'm also board member at the Dutch branch of the EMA, so the Dutch Medicines Evaluation Board. And from that perspective, I will talk a little bit about the impact of surrogate endpoints for regulatory purposes. So that's not necessarily only phase 2 studies, if you can shorten phase 2 studies, but in general, what can we do with surrogate endpoints, and what's the value of those? So therefore, the title is with the benefit-risk assessments, which is typically a regulatory term, of course. These are some disclosures, and importantly, this is my own personal view. This is not the view of EMA or the Medicines Evaluation Board or the Netherlands Cancer Institute. So you can only blame me if you don't agree. Well, just to start off, this is a publication of just this week in Lancet Oncology that we did in breast cancer. And the question that we set out on studying, that was about 3 years ago, is if you treat HER2-positive breast cancer, do you need anthracyclines? And the rationale for that question is, of course, that the anthracyclines have a cardiotoxic profile, and if you give anti-HER2 drugs, they also have a cardiotoxic profile. Do we really need that? And in designing the study, we thought about using a surrogate endpoint, namely the pathological complete response rate, in a randomization between women getting an anthracycline containing versus those getting a non-anthracycline containing regimen. And what we found was that the pathological complete response rate after both regimen is, well, virtually equal. It's 67 versus 68%. Well, apart from being a very nice result and questioning the value of surgery in these women, if you have a pathological complete response after neoadjuvant chemotherapy, the question now, of course, is this sufficient evidence that you don't need anthracyclines if you give neoadjuvant chemotherapy to these women, including trastuzumab and pertuzumab? So maybe just raise your hands if you think that from now on we can abandon anthracyclines based on this result. And of course, most of us just don't want to raise hands, so then raise your hands if you think we should still use those. So not many breast cancer specialists here in the room, I think. That's a fair answer as well. So our conclusion actually is that, of course, you need further follow-up. That's something you always say in a study, and more studies are needed. I think in the meanwhile, we can use a non-anthracycline containing regimen if this is a very solid endpoint, and we'll get back to this, why I think this is a solid endpoint in this case. But still, you need to confirm this with a really, really important clinical endpoint, relevant endpoint. So the benefit-risk assessment, what's it all about? Well, it's nothing more than it actually says. So what are the benefits of the drug and what are the risks of the drug? And it's mostly on a regulatory basis. If you discuss new indications, do you have sufficient evidence that this is really giving a patient a benefit, and does it outweigh the risks it has? And there's a couple of formal steps that you have to take, and we take at the Medicines Evaluation Board, and people at EMA do so as well. So first of all, what's the therapeutic context that you look at for this particular drug or this particular indication? What is the tumor type? What's the mode of action of the drug? Is there a specific subgroup of patients? What is the comparative or the standard of care at the moment that you compare it with? Then, of course, you have the favorable effects, and what is the actual study results, and we get a little bit to that, but also what are the uncertainties in this effect that you've shown, and are there limitations in the amount of the evidence that we have, and the same holds true for the unfavorable effects. And if you collect all those data and all that information, then you can come to a benefit-risk assessment, and we'll talk a little bit about that, whether that is as factual as the actual study results or whether that's more of a subjective interpretation, which each person can make for his or her own. So favorable effects are actually something quite factual, as I said. So what's the primary endpoint of this study? And that can be a response rate, or that can be overall survival, something that we actually measure in patients and we give with confidence intervals as the statisticians help us to do so. You may also describe key effects in subgroups. It can be very important, and there's a lot to do in statistics, but also in epidemiology on how to deal with subgroups. And is this a valid endpoint, or does it introduce a lot of uncertainties? Did you predefine those? Are they post hoc evaluated? And sometimes you can also consider dose and PK/PD issues if that's important for a particular question. And I didn't put on the same slide for the unfavorable effects, but of course you need to look at the adverse events, the serious adverse events, which are particular for this patient group, which may be very different if you look for if you study a hypertensive drug or if you study a chemotherapy drug or immune therapy drug. So some of the uncertainties that you always have to consider, and these are not new issues, but it's always good to have a sort of a list and you go over those. So what is the statistical issues? Do you have enough certainty? Was the study adequately powered to make the statements that you do? What are sensitivity issues? Was this a single study? Was it designed as a pivotal study, or was it actually a short phase 2 study which is not designed for regulatory purposes? How much missing data were there, and how were those handled? Were they filled in, or were they just left open? And then, of course, what are the key effects that you're studying? And is this a relevant key effect for this question that you're asking? And then you also get to the point of surrogate endpoints. Is this surrogate endpoint, if you use a surrogate endpoint in a study, is this an important endpoint? Is it something that you can actually use? Of course, external validity. Does the study population have any bearing on the patients outside of the study? How far can you extrapolate these findings? And are there inconsistencies with the literature that we know so far? If you find something completely different from what you expected of what is known with similar drugs, then of course that raises some questions about the validity and also how much you trust the data. And if you get to that stage and you do the same thing for the unfavorable effects, then you can make a trade-off. How much certainty do you have that the favorable effects are true, and does it weigh up? Does the uncertainty weigh up against the benefits or the unfavorable effects? If there is uncertainty, you can always also ask what additional data do we need to get more certainty and sufficient certainty to get to a regulatory decision. And you may also decide as a regulator that you need additional data post-authorization, so a post-marketing survey or even additional data, and you may go for a conditional approval if in selective circumstances. And actually this is sort of a table of the benefit-risk assessment that you can make. So you start off with the therapeutic context, what is the mode of action, what is the setting that you treat a drug or you test a drug, and you look at the favorable and the unfavorable effects and the certainty that you have. But then you get to the importance of this benefit-risk assessment. How much uncertainty are you willing to accept given the context? And if there's a very high clinical need, and typically all oncology drugs are considered as a high clinical need because oncology is a potentially fatal disease. So I think this concept is used quite broadly, maybe even too broadly. But you're willing to accept more uncertainty if you have a higher clinical need. For instance, meaning there is no alternative treatment, there is nothing left for these patients, or the overall survival without any treatment is very poor. But still, how do you weigh one against the other? I don't think there's factual evidence for that. That's something that people make for themselves. How much risk are you willing to take for a drug? And even each patient does that in a different way. And also regulators can do that in a different way. So these are often the discussion that we all have the same data, but people value it in a different way. And I think therefore it's also important to weigh a cultural context and also a financial context even, although the financial context is not something that the regulators can take into account. But still it's a very important thing to weigh, I think. So what are the favorable effects actually that we have to look at in oncology? And in the long run, in the end, patients want to live as long as possible with as good as possible quality of life. I think these are actually the only important endpoints that you have to that you really want to look at. But of course, there's difficulties in assessing these. Going for overall survival, depending on the subtype or the tumor type, it can take a very long time to collect the data. It can be influenced by competing risks, so you don't actually look at the biological effect of your drug if there's many, for instance, cardiovascular comorbidity. In a metastatic setting, it can also be obscured by crossover, and you will never be able to even detect a overall survival benefit. And there can be more downsides or difficulties in assessing the overall survival benefit. And quality of life, although very, very important, I think we all think it's very important, but it's so difficult to measure in many circumstances. Partly because you can say it's insensitive to change. You can also say that people have a high ability to adjust to new circumstances. I'm always very struck by patients who are in looking from the outside, a poor condition, and they just say, I'm having the best time of my life. Even if they have a short time to live, but just because they live with their family, have better contact, their quality of life can be very good. And then that's not always intuitive from an objective point of view. So that's a difficulty with quality of life. And that's a reason why there's a need for surrogate endpoints in many circumstances. Just as some definitions, what do we mean by a surrogate endpoint? So that's a biomarker. It's intended for a substitute for a clinically relevant endpoint. And it should also predict that clinical benefit. And you see the definition that are typically used as a clinical endpoint. That's not very surprising, but something how a patient really feels, function, or how it affects survival. And a biomarker is something that can be objectively measured. I think that is important. And it can be an indicator of various physiological or pathological processes. So I think in oncology we make a lot of use of surrogate endpoints. I mean, response rate is one of the first things we look at. But of course, response rate is just based on some definitions that the RECIST criteria commission once set for us. And the patient doesn't really notice whether the shrinkage or the increase in tumor size passes that border of 20 or 25%. It's something that we just set up as a definition. Time to event endpoints, of course, it's in some way related to the response. What's the moment and at what time point do you reach that certain increase or decrease in tumor size? And also recurrence-free survival, of course, in the end is a surrogate for overall survival. So I put on two other surrogate endpoints, and there's the pathological complete response rate that we use in our study. And this is not just as a coincidence I take this, because this is only one of the few surrogate endpoints that have been approved by EMA for use in clinical study. And the other one in breast cancer. And the other one is minimal residual disease in myeloma that's being considered. And just put up for the sake of discussion here, what's the value of liquid biopsy, because the next talk will be on liquid biopsy, and we can discuss whether we can use those as a clinical endpoint or a surrogate endpoint. A little more about the neoadjuvant chemotherapy in breast cancer and why that would be a good or not so good surrogate endpoint. Below you see an MRI of a woman with HER2-positive breast cancer, and there's a clear tumor in the breast. And then you see the same woman after neoadjuvant treatment in our study, and there's a complete radiologic response at least, and it proved out to be a complete pathologic response as well. And so what can be the reason to treat patients in a neoadjuvant setting? It's not just to improve survival, but there's a clear improvement in quality of life by increasing the probability of a breast conserving and axilla conserving surgery. So it does improve quality of life as well. But from a medical oncologist point of view, there's an early treatment of systemic disease. Patients never die from their primary tumor, they die from distant metastases. And if there are microscopic distant metastases, you better treat them early and not wait for the surgeon to be ready and the radiotherapist to be ready to start the most effective and the most important treatment. So start early, treat first what kills first, as a slogan. And then, of course, it's much better to have a response monitoring. If you give an adjuvant treatment, so after you remove the primary tumor, there's nothing to monitor anymore, and it's just giving the chemotherapy in the blind, which is effective in the statistical point of view. But if you look at the tumor and you see it's not responding, you can adjust your treatment to a more effective regimen. So monitoring and adjusting your regimen is a big potential advantage of neoadjuvant treatment. And then at the last point, and that's most related to this talk, is that this can be a surrogate endpoint for long-term survival, for progression-free, disease-free, but most importantly, overall survival. At least that's the claim that many people are making. And the question is whether that's a fair claim. Is it really a surrogate for long-term outcome? There's a study or an analysis presented or published a few years ago by Cortazar and colleagues, which looks at the relation between pathologic complete response rate in various studies and the long-term outcome. And what you see here is, across many studies, patients that do achieve a complete pathologic complete response in red with those who do not, who have residual invasive tumor cells after neoadjuvant therapy. There's a clear distinguishing, clear divergence of the curves, meaning it's a strong prognostic factor with a very statistically significant hazard ratio. But that's not the complete story, because if you're going to look at a trial level, and that's shown here, so all dots are individual trials that have both early endpoint, pathologic complete response, and a long-term outcome in event-free survival on the left or overall survival. And you plot the hazard ratio for overall survival or event-free survival with the odds ratio for a complete pathologic response. You would ideally have a strong correlation with all curves on the same line and a almost a correlation coefficient of 1. But quite on the contrary, you see almost no correlation at all. So whether or not you reach a complete pathologic response or not doesn't seem to say much about whether you're going to survive very long. So that's quite something to think about. So why is this so? And then also, why should pathologic complete response be a surrogate and be used for endpoints in studies? Getting back to this scheme, if this is the reality that one of the strongest, at least the approved surrogate endpoints that EMA has so much uncertainty because you actually don't know what you're measuring, then this is more of a situation that you have favorable effects, but there's so much uncertainty, and are you willing to accept that uncertainty? How are you going to deal with this if there's an indication for a drug and a patient asks you, well, what's the benefit that I'm going to get? Am I really going to live longer for this? I said, maybe you don't really know. And also, how do you weigh this benefit against the side effects? There's a benefit in a endpoint that you don't really know its value about. So how can you compare that? How can you make a judgment about a benefit risk assessment if you don't really know what the benefits are? So why is pathological complete response not a perfect surrogate? Well, there can be many reasons. To start off, one can suspect there's sampling error. I mean, the pathologist doesn't look at every single slide. He's got definitions about on how many slides in the resection specimen he will look for, or she will look for residual disease, and there can be single individual invasive cells in between that are missed. There's also various definitions that are used across these studies. Some say that you can still have ductal carcinoma in situ in your resection specimen. It still counts as a pathologic complete response, whereas others don't. So the study is sort of biased, or the analysis by Cortazar can be sort of biased in what definitions are used. Do you count the axilla as well? You're only looking at the breast, or you look at the breast and the axilla for a complete response? And it matters in how strong the relation can be with the long-term outcome. Now, the other thing is that a lot of patients that get a pathologic complete response needn't have a pathologic complete response in order to be cured, because they would have been cured by the surgeon as well. If you just took out the tumor, there were no microscopic disease, distant disease, they would still have been cured. So despite not having a pathologic complete response, patient can be cured. So there's not a perfect relation there as well. And then you have radiotherapy, and you also get adjuvant chemotherapy or adjuvant endocrine therapy and trastuzumab as well. So even if you don't have a pathologic complete response at the surgery, you can still get additional benefit from the adjuvant treatment. So these are all factors that you have to take into account to weigh the benefits of such a surrogate endpoint. And then one last important thing is there can be tumor heterogeneity, and that can be within a tumor, that the distant disease is not the same as the disease in the breast and therefore responds different to the drugs that you're administering. But it can also be heterogeneity between subgroup of patients, meaning that one breast cancer is not the same as the other, and that is something that's particularly true in this case. That's why I will show you these other curves from the Cortazar paper, and that we know quite well, is that the value of pathologic complete response is much different if you look at the luminal tumor, so that's a hormone receptor positive, HER2 negative tumor, and if you compare that to a HER2 positive, ER negative tumor, whereas the curves diverge quite strongly in the latter. It's hardly prognostic, or it's not prognostic at all in the first. So the value of a surrogate endpoint very much depends on the context and the tumor type and also the tumor subtype. And these are all things that I think in order for a surrogate endpoint to be used, you must be very well aware of. So how does this endpoint actually perform in this particular situation for this particular subgroup? And only if you know that very well, then you can consider using it. In various guidelines, EMA has touched upon this topic without a very strong guideline itself, but just going over various ones, you can come to some statements. So the use of surrogate endpoint may be used, may be considered for a clinical endpoint. So that's a good start. You can consider it. It needs to be a validated biomarker, so the assay needs to be validated. You need to be, you need to know what you're actually measuring. And it needs to be internally consistent. It needs to be reasonably likely, and this is of course a subjective term. I would rather say very likely that it predicts a real clinical benefit, and this has got to do with the curves I showed you from the Cortazar paper. Nevertheless, I mean, if the prediction is not very good, or if you're not very certain, then the clinical benefit and the benefit risk assessment will be much more difficult to assess. So for a regulator, this will be a very difficult thing if you need to assess that. It can never serve as a final proof, so you need to have a longer term outcome, and you need to have longer term data to prove what you're actually claiming. And actually you should have that plan on how you're going to predict those, how you're going to collect those long-term data in upfront ready. So you need to convince that it's certain that you're going to get those data, and it's not left open for chance, and it's maybe you'll collect it or maybe not. I found this cartoon, which is also, I think, important for our patients. Do we really need a rule to not harm patients? I think that should be very clear, but it's got to do with the subjectiveness of the benefit risk assessment. So what side of the table are you on? Are you thinking that if there's a potential benefit of a drug, you need to give it to all patients, or if there's a potential harm, you will not give it to any patient? And how much certainty do you take in this? I think none of our drugs are 100% sure to work for patients. You're gonna harm some patients. So how much certainty do you need for a patient to get the drug, and how much certainty do you want that it's not gonna harm? And although it's not a regulatory issue, I think cost is very important. Those from the Netherlands can read this. This is from the news today. This is the insurance, the prices that we have to pay for our health insurance. It's rising this year with about 7 to 10%. And that's of course got to do with a lot of interventions that we as clinicians offer to our patients. And only if you give intervention that we know are very effective, it's good value for money. And if you give a lot of intervention that are hardly benefiting anyone, it's not good value for money. And if we come to a situation that we accept much more increasing amount of uncertainty in our decisions about whether a drug is effective or not, we're going to increase or we're going to decrease the value for money that we give to our patients by our intervention. So I think it's really important issue that we need to get as much solid information and as much data-driven information as possible to prevent also the cost increase in healthcare. So in conclusion, I think surrogate endpoints may show early signs of biologic activity, and that's mostly related, I think, to the topic of this session. For a phase 2 study, it can be very important and show whether or not you're on the right track and go for a longer, for a next study that can be a pivotal study with a clinically relevant endpoint. Because the association with clinical relevant endpoint is very often uncertain. From a regulatory point of view, I think there should be very strong evidence that the surrogate endpoint predicts a clinically relevant endpoint. And only if you know that for that specific tumor type or tumor subtypes, you may consider using it if there is a clinical need and there's no really possibility to get a clinical endpoint in your study. We also discussed that in the end, the benefit risk assessment is subjective. It depends on your own values, on your cultural background, on the possibilities of your health insurance companies, whether or not they are going to be able to afford things. And a final statement that we very much need to balance the overtreatment and undertreatment of patients. And that is something that you do with your patient as a shared decision making, but also I think as policymakers and also as researchers, we have a responsibility to do studies that give us as much information as possible, and we don't need to. We should be careful not to give drugs that have too much uncertainty that we cannot make this decision with our patients. And with that, I'd like to thank you for your attention, and I think we have a discussion afterwards.